Good morning, everyone. Myself, Dr. Radha Chouhan, Assistant Professor in Department of Prosthodontic, Crown and Bridge. So today we will be learning about mandibular movements. So these are the content, significance of understanding mandibular movements, structure, anatomy and functions of temporomandibular joints, some definitions, determinants of mandibular movements including condylar guidance, incisal guidance and neuromuscular factors, methods of classification of mandibular movements and methods of recording mandibular movements. So as we know, why do we need to study mandibular movements? Our main goal is to maintain or re-establishment of good occlusion when treatment is completed. The neuromuscular coordination should be in good harmony. There should not be any interference in the occlusion. So we need to understand about the coordination between the neuromuscular coordination and the anatomy of TMJ. So what is temporomandibular joint? It is a bilateral diarthroidal synovial hinge joint. The joint is composed of capsule and articulating disc. The glenoid fossa and condyle form the articulating surface. There are two compartments, the upper compartment and the lower compartment. The upper compartment is responsible for gliding movement and the lower compartment is responsible for hinge movement, that is rotatory movement. These are some definitions. Centric relation, it is a relation between, it is a maxillomandibular relation in which the condyle articulate in the anterior-superior position against the posterior slope of articular eminences. It is a purely rotary movement. The patient can make vertical, lateral or protrusive movement. What is centric occlusion? It is the occlusion of opposing teeth when the mandible is in centric relation. It may be or may not be coincide with the maximal intercuspal position. What is MIP? It is a complete intercuspation of the opposing teeth independent of condylar position. What is working side of condyle? The side towards the mandible move in lateral excursion. What is balancing condyle or non-working condyle? The path of condyle transfers on the non-working side when the mandible move in the lateral excursion. What is terminal hinge axis? An imaginary line around which the mandible may rotate within the sagittal plane, only in one plane. So what are the determinants of mandibular movements? There are three factors, the condylar guidance, incisal guidance and neuromuscular factors. Condylar guidance, it is the posterior determinant of mandibular movement. It is the mandibular guidance generated by the condyle and the articular disc transversing the contour of glenoid fossa. The condyle move along the surface of glenoid fossa. The shape of glenoid fossa is S shape. So the path of movement taken by the condyle in the glenoid fossa is condylar guidance. What is the clinical significance of condylar guidance? If there is shallow condylar guidance, there will be less amount of separation. So we will be using shorter cusp in occlusion. If there is steep condylar guidance, means the condylar guidance is deep, the amount of mouth separation is increased, sharper and taller cusp is needed. Incisal guidance, it is the anterior determinant of mandibular movement. It is the influence of contacting surface of maxillary and mandibular teeth, anterior teeth during mandibular movement. The angle formed between the long axis of upper and lower anteriors are known as incisal guide angle. If there is greater horizontal overlap, there will be less steep incisal guidance. If the greater vertical overlap, there will be more steep incisal guidance. The neuromuscular factor. There are some muscles of mastication which are important determinant of mandibular movement. The lateral pterygoid muscle control protrusion. The medial pterygoid and masseter muscle control lateral movements. And the temporalis control retraction and closure of mandible. This is the classification of mandibular movement on the basis of dimension, on the basis of type of movement, on the basis of extent of movement. On the basis of dimension, there are rotation around the transverse axis, vertical axis and sagittal axis. On the basis of type of movement, hinge movement, protrusive, retrusive or lateral movements. On the basis of extent, there are border movements and intra-border movements. In border movement in the horizontal, sagittal or vertical plane. Rotation around the transverse axis or hinge axis means in the horizontal plane. Transverse axis run horizontally from the right side of mandible to the left, Rotation is seen during mouth opening or protrusive movement. The transverse axis varies during different phases of protrusive movement. Around the anterior-posterior or sagittal plane, condyle on one side move downward and medially along with medial slope of glenoid fossa. And condyle of the opposite side move upward and laterally. It is usually seen with lateral movements. Rotation around vertical axis. Mandible rotate around the vertical axis during the lateral movements. If the patient moves his mandible towards the right, the vertical axis of rotation will pass through the right condyle and vice versa. On the basis of type of movement, hinge movement, protrusive, retrusive, or lateral movements. What is hinge movement? It is purely rotational movement in horizontal axis till the patient opens his mouth to about 20 to 25 mm. It occurs 10 to 13 degree rotation of the condyle in temporomandibular joint. It occurs during taking or crushing food. Mandible begins to glide after certain amount of jaw opening, after 13 degree of rotation. It is produced by the action of lateral pterygoid and suprahyoid muscle. Protrusive movement. It occurs during incising or grasping food. It occurs after condyle rotate for more than 13 degree. The mandible slides forward, means edge to edge relation of the anterior teeth. When there is edge to edge relation of anterior teeth, there will be posterior disocclusion of the teeth. This is known as Christensen's phenomenon. It is produced by lateral pterygoid and suprahyoid muscle. Retrusive movement. Mandible forcibly moves behind the centric relation. It is achieved by fibers of temporalis, digastric, and the deep fibers of masseter muscle. The magnitude of movement is about 0.5 mm. It is not a common movement and patient cannot voluntarily reproduce it. Lateral movements. There are two types of lateral movements: lateral rotation or Bennett movement. Lateral rotation is mandible move away from the mid-sagittal plane. These movements can occur on the right side or the left side of mandible. When the mandible move towards right side, right condyle considered as working side, or left condyle is known as non-working or balancing condyle. What is Bennett movement? Bodily lateral movement or bodily shift of the mandible resulting from movement of the condyle along the lateral excursion, incline along the mandibular fossa in lateral jaw movement. It is bodily side shift of the mandible. During lateral movement, mandible is shift by 1 to 4 mm towards the working side. There are three types of Bennett shift: immediate, precurrent, or progressive. What is Bennett angle? The angle formed within the sagittal plane and the path of advancing condyle during lateral mandibular movement as viewed in the horizontal plane. The angle formed between path of non-working condyle and the sagittal plane is known as Bennett angle. It is about, the studies have shown the Bennett angle is to be about 7.5 to 12.8 degree. To calculate the Bennett angle in a Hanau's articulator, is Bennett angle is equal to h by 8 plus 12, where h is horizontal condylar inclination. The clinical significance of Bennett angle is, if there is more Bennett movement, cusp of posterior teeth should be shorter or occlusal fossa should be wider. The steeper the Bennett angle, narrower will be the cusp, or shallower the Bennett angle, broader the cusp will be maintained. Border movements. Mandibular movement at the limits dictated by anatomical structure is known as border movement. There are three border movements. First is extreme movement in the horizontal plane. It shows a rhomboid shaped pattern that is known as diamond tracing. The patient is instructed to move his mandible first in the centric relation, from centric relation to maximal right lateral position, then maximal protrusive position and the maximum left lateral position, and it will be returned to centric relation again. Border movement in the sagittal plane, there will be a beak shaped tracing will be formed. The patient is instructed to move the mandible from centric relation to centric occlusion, then centric occlusion from centric occlusion to edge relation, that is that will be protrusive movement, then forward to maximal protrusive position, then downward to maximal mouth opening position. Once this position is reached, the operator should guide the mandible to backward and close the mouth. Extreme movements in the coronal plane. There will be a shield tracing. The patient is instructed to move his mandible in centric occlusion, from centric occlusion to canine guided disocclusion on the right side, then the maximal right lateral position, then they from right lateral position to maximal mouth opening. Then the patient is instructed to arc upward in the maximal left lateral position, and then return medially to canine guided disocclusion in the left side, and then return to centric occlusion. Envelope of motion. The combined border movement of the three planes is known as envelope of motion. It is described by Posselt in 1952. As the jaw separation increases, space for movement decreases to a zero at the maximum mouth opening. These are the maximum movements: opening, lateral, protrusive and retrusive range. Intraborder movements. They are functional, parafunctional movements. Functional movements include chewing, speech, mastication. So in chewing cycle, there are 6 phases which form teardrop tracing. Parafunctional movement, it includes clenching, bruxism or other habitual movements. These are the methods of recording mandibular movements, including photographic method, electronic or telemetric method, magnetometry, etc. So the conclusion is jaw movement or mandibular kinematic application in many fields of clinical dentistry and dental occlusion. For replacement of teeth and restoring function, a dentist must have a knowledge of mandibular movement as it aids in selection and programming of articulator, understanding occlusal fabrication, dental prosthesis, and arranging artificial teeth. These are the associated questions asked in Viva and theory as well. Thank you.